Thank you. Stephen.
Thank you very much indeed. Good morning. Thank you for asking me to provide an update on sutureless aortic valve surgery. I was pleased actually to see there wasn't a third option on the poll there for sutureless aortic valve replacement. I don't think we're quite there yet, and I'll show you why that is the case. So when we talk about sutureless valve replacement, we always think that we're at the cutting edge of aortic valve replacement, but actually it's important to understand that sutureless valves are not something completely new. McGovern and Cromie designed the first sutureless valve in 1962 with the aim of rapidly fixating the valve into the heart and lessening cardiopulmonary bypass time. And their valve prosthesis was loosely based on the Starr-Edwards ball and cage principle, but had a number of small hooks that would lock into the aortic annulus and provide you with a way of very rapidly inserting the valve. Just last year, you might think that because of that technology, the durability of that valve being antiquated would be very poor, but just last year there was this case report indicating that one of these valves was actually still functioning absolutely perfectly 42 years later, so perhaps it is in some way indicative of the principle of sutureless valves being something that are applicable to our patients. So let's jump forward in time now and look at the modern era and think about the main players in the sutureless aortic valve world. Now, in 2014, the Medtronic 3F Enable valve was withdrawn from the market, and that leaves us with two contenders now, the Livanova Perceval valve and the Edwards Intuity valve, which were CE marked in 2011 and 2012 respectively. But as you can see, they take a rather different approach to the design and technology of the valve. For those of you who aren't completely familiar with these prostheses, it's worth just spending a couple of moments just looking at the valves and how they're inserted. So the Edwards Intuity Elite is a stented valve. It's based on the Perimount Magna Ease pericardial valve that we all know well, but has a subannular expandable skirt. So we have a very proven platform. The sizing technique for the valve is very familiar. It's no different to sizing a conventional perimount valve, and has these three guiding sutures that are placed into the annulus and through the valve to allow you to parachute the valve down into position and ensure that it does not pass too far through into the left ventricular outflow tract. The skirt's then balloon expanded to 4.5 atmospheres for 10 seconds to place the valve into position, and then the three guiding sutures are tied. The results of this valve have been very impressive. The TRITON study looked at the gradients that were achievable over a 3-year period, and they were very acceptable. And partly the very good gradients across the valve are due to the flaring effect of that skirt that sits in the subannular position. Now, the Perceval valve takes a very different approach to this technology. Again, it's bovine pericardial leaflets, but the leaflets are based within an expandable and collapsible nitinol frame. The valve comes in 4 sizes, which are broadly categorized into small, medium, large, and extra large, but encompass a range of diameters of aortic annulus. The valve is collapsed onto a holder for delivery into the aorta. And there are 3 guide sutures which are placed through the valve, which simply mean, which are simply there to make sure that the valve doesn't pass too far into the left ventricular outflow tract. And those sutures can be removed after the valve's implanted. Deployment of the valve involves turning a handle at the end of the delivery system to release the inflow portion of the valve, and then pulling up on the shaft of the instrument to release the outflow portion of the valve. And then there's a second point of implantation technique where a balloon is placed through the valve, and then there's a balloon inflation of 4 atmospheres for 30 seconds to implant the valve fully. However, with the Livanova Perceval valve, you have to be very aware that the sizing is critical to getting a good result, and patient selection is also based upon the echocardiographic assessment of the patient. The echocardiography intraoperatively has to measure the sinotubular junction and annular diameters and the distance between them to ensure that the frame and the stent of the valve is going to be correctly positioned for the best result in the patient. And importantly, the sinotubular junction to annular ratio mustn't exceed 1.3 to ensure the best result in the patient. So not only are there operative surgical steps, but you're very reliant on your anesthetic colleagues in the transesophageal echo to ensure that this valve is placed with the best possible result. So what does this mean for patients? How does this technology benefit the people that we operate on? Well, there have been a number of studies performed looking at cross-clamp time in the Livanova Perceval valve and also in the Intuity valve, and they have shown reductions in cross-clamp time of somewhere between 20 and 50% depending on the study that's been performed. If we look at larger series, and in particular here I've got a graph from the Society of Thoracic Surgeons in the US, looking at conventional implants of stented aortic valves against sutureless valves, and you can see quite significant reductions in cross-clamp time from 78 minutes to 33 minutes and bypass time from 106 minutes to 57 minutes. As well as reducing bypass time and cross-clamp time, there's also a lot of evidence forming that there are significantly improved haemodynamics in sutureless valves compared to stented valves. And I've shown a paper here that was just published a few weeks ago, which was a meta-analysis looking at nearly 1,400 patients who had had a Perceval implant compared with a conventional stented valve. And this showed superior gradients in effective orifice areas, both at the 30-day and 1-year mark. So there have also been similar studies done on the Intuity valve with very analogous results. So what are the pragmatic benefits of that then for the patients? Well, we know that there's a relationship between cross-clamp time and bypass time and 30-day mortality. So intuitively, it would benefit patients who were elderly or frail, patients who were in the TAVI category but had been turned down for technical reasons, patients who have significant comorbidities such as renal dysfunction, pulmonary disease, and so on, and also the advantageous hemodynamics with a large orifice area and low gradients might favour the use of sutureless valves in patients with poor ventricles. Also, the delivery systems do permit the use of minimally invasive approaches with with a lot of ease, and brings with it those advantages of that incisional approach. Now, there have been a lot of studies looking at the initial outcomes after sutureless valve implantation, and you can see from this table that there are significant advantages in patients from an inpatient point of view. So we see a reduction in ventilation time, shorter intensive care and hospital stays, less atrial fibrillation, and less bleeding. And this is something that we've seen in our own practice using the Perceval valve in Newcastle, and there's an abstract going to be presented tomorrow on our own experiences, but they mirror essentially the findings in this particular paper. As a result of these savings in time, a lot of European centres have demonstrated cost savings between 15 and 30%, and there's also been an application to get sutureless valves onto the high-cost tariff excluded devices list in the same way that TAVI is, which will provide some financial advantage to the providers. So, what about outcome studies? Where are we in terms of clinical outcomes with these patients? So I'm just going to run through some of the shorter-term trials that have been published to give you an idea of where we currently sit. So the Perceval valve was evaluated in the CAVALIER trial, looking at 658 patients, and this gave very good short-term outcomes, very similar to what we would expect for conventional aortic valve replacement, with very low rates of reoperation and removal of valves for paravalvular leaks, just 0.8% in that series. And again, confirmed that in real-world use across a number of European centres, cross-clamp times were dramatically reduced down to about 35 minutes on average in that series. For the Edwards Intuity valve, the Transform trial that was undertaken in the United States gave us a good idea of short-term outcomes for that particular type of sutureless valve. So in over 800 patients, we saw a 95% implant success rate, very low mortality, excellent hemodynamics, and only a 1.6% paravalvular leak rate at 1 year. However, the concerning feature in this particular study was the very high level of pacemaker implantation, nearly 12% in this study. However, if you just get into the background of the data and look at the pacemaker figures, you find that over half of the pacemakers were actually implanted within 4 to 10 days after the operation, which by UK standards certainly would be a very short period of time. I think most of us would wait longer than that. And also the data was skewed by 2 centres which had a particularly high rate of pacemaker implantation compared to the rest. It's reassuring then that a study that was just published a few weeks ago from Europe, the Foundation trial, looking at the Edwards Intuity valve across a number of European centres, actually demonstrated a pacemaker rate of around 6%, not 12%, with a very low rate of explantation of 0.8%. So I think in many ways we can be reassured that the pacemaker rate isn't unduly high for this particular type of valve. So those are some one-year studies and some studies that show you the outcomes out to 30 days and also slightly longer term. But since the valves have been out since 2011, 2012, we now have the opportunity to look at some longer-term follow-up studies which go out to 5 years. And while I appreciate that that's not a very long period of time, that's all the period of time that we have in terms of follow-up for these valves. So for the Perceval valve, this study in over 700 patients looked at outcomes to the 5-year point and showed excellent clinical results. There was a very low paravalvular leak rate of 1.4% in that period of time, 6% pacemaker implantation rate, and no dislodgement of the valve or migration, and no structural valve deterioration over that period of time. However, there is, at the moment, the PERSIST AVR trial underway across Europe, recruiting 1,200 patients across 60 centres in a prospective multi-centre trial, which will evaluate the Perceval valve against conventional stented valves, and that will report in 2019. So we will have some more informative 5-year follow-up data at that point. If we look at some of the 5-year studies on the Edwards Intuity valve out to 5 years, we can see similar encouraging results at that time point. The TRITON study demonstrated very good durability, 81% of patients doing well with no events at 5 years, and permanent pacemaker rate of around 5% and an explant rate of around 2%. So which of these valves is better? We've had a huge number of studies looking at the Perceval valve and the Intuity valve, but only one study that's actually compared the two, which was done in Germany. And this was only published a few weeks ago, but I thought I'd share it with you. And essentially what we see here is that when you compare the Perceval and the Intuity valve, the cross-clamp time and bypass times are pretty much identical, and the haemodynamics also are very similar. However, I would say that the paper reports the Intuity 21mm against the Perceval S or small type, and we have to remember that the Perceval covers a range of sizes. So the Perceval S will also have been implanted in an annulus of 19 to 21mm, not just 21mm. So we're not quite comparing the same thing there, but the haemodynamics appear to be broadly similar. Also, when you looked at other complications of the valve, implantation and any valve-related complications, there were no significant differences between the two valves. So it certainly seems that although the technologies are very different, the results are identical in the one study that has been performed that compares the two. So who should we use these valves in, and what benefits do we think they bring? So we can get some guidance from a consensus statement which was put out in 2016 and brought together 31 surgeons from around the world who had experience in sutureless and sutured aortic valves to review all of the literature, which was over 1,000 papers on sutureless valves, to try to distill all of that down into guidance that we can use in practical terms in our everyday practice. And so I've summarized that in a couple of tables. So the weight of the literature supports the use of the valve in patients over 65 years of age until we have better longer-term durability data. Certainly, it favoured its use in high morbidity patients with calcified aortas, and the annulus must be greater than 19 millimeters. It was also recommended that the valve be used in previous homografts. For bicuspid valves, there is a variety of evidence, but the basis is that you could use it in a bicuspid valve provided the commissures are of equal height and you have 1 or 2 raphes. The weight of the literature, however, does not recommend the use of sutureless valves where you need to do an annular enlargement procedure, where the patient has active endocarditis, or in patients with aortic regurgitation. In terms of short-term outcomes, the literature was very clear that using sutureless valves did reduce ventilation time, reduced blood loss, reduced atrial fibrillation and ITU stay and hospital stay, but was associated with an increase in permanent pacemaker insertion after the operation. So what about the future of sutureless valves, and where do we go from here? Well, firstly, I think we need to address some cynicism about the importance of reducing cross-clamp time and bypass time. And if we look at the results of the Transform study, for example, that gave a cross-clamp time of around 49 minutes for the implantation of the Intuity valve. However, when we looked at our own data in Newcastle, and I'm sure this would be the same for all of the UK centres, this is standard aortic valve replacements with the Paramount Magna Ease valve, which essentially is a sutured version of the sutureless Intuity valve. We found our cross-clamp time was actually 59 minutes. That encompassed consultants, staff grades, trainees, everybody doing aortic valve replacements. So the actual reductions in cross-clamp time amounted to only 10 minutes. And does this actually make a difference to patients? So we have to be wary of real-world comparisons outside of the studies. However, we do need to continue to be vigilant about the incidence of paravalvular leaks and pacemaker implantation. Going back to the paper that I showed you earlier that was published this year, which was a meta-analysis of Perceval valves against conventional stented valves, the meta-analyses did suggest a trend towards increased permanent pacemaker insertion and of increased rates of paravalvular leakage. But we do have to take into account the impact of the learning curve, institutional differences, particularly in terms of pacemaker implantation, and that the techniques are going through technical evolution all the time, that these devices will improve and the technique to implant them will also change. So, for example, there are many surgeons now implanting the Perceval valve without the secondary balloon inflation step, and that seems to be having a significant impact on pacemaker rate. So, as confidence has risen and experience has been gained in the use of sutureless valves, we've seen a widening of application of these prostheses into our medical and surgical practice. And I've just picked out a number of papers here demonstrating the use of sutureless valves as an alternative to aortic root enlargement, for example, using calcified homografts in small aortic roots in the elderly and in the redo setting, for example. So we are certainly moving beyond our traditional comfort zone with these prostheses, and they now have many applications in our general cardiac surgical practice. But the real battle that we face, of course, as was mentioned this morning, is with TAVI. And it might be interesting just to share one meta-analysis that was actually published in the Journal of Cardiology, looking at 7 studies and just over 900 patients who'd undergone sutureless aortic valve replacement or TAVI. And this actually demonstrated a lower mortality, lower rate of paravalvular leak, and a lower pacemaker rate than the patients who had undergone TAVI. So this is useful information as we try to set out which patients would be better served with TAVI, those would be better served with surgical aortic valve replacement, and sutureless aortic valve replacement might bring us some benefits in that regard. So my conclusions then, as an update on where we sit now with sutureless aortic valve replacement, is that the prostheses that we use are based on proven technology. The leaflet technology that's used in those valves is the same as that we would use in conventional stented valves. But it does require mastery of new techniques, and it is very important to pay particular attention to the sizing of the valves to make sure that they are suitable for that particular patient, and to follow all of the steps to make sure that the outcome is as best as we can possibly get. There is a lot of evidence to suggest that sutureless valves will shorten cross-clamp time and bypass times, and that those valves have an advantage over stented prostheses by increasing the orifice area and reducing the gradient across the valve. And a lot of clinical evidence now that certainly in the short term there are benefits to patients in terms of reduced ITU stay and reduced hospital stay. The valves can now be widely applied in a variety of clinical situations, not just for simple aortic valve replacement. And the follow-up data that we have so far is very favourable at 30 days, 1 year, and 5 years. But of course, the proof is in the pudding of long-term follow-up out to 10, 15, and 20 years, which will come in due course. As far as the comparison that we can make so far, the Perceval and the Intuity appear to be very similar in terms of clinical outcome, and there isn't one that is better than the other. And the consensus paper of 2016 still gives us a very good, clear understanding of where these valves should be applied and the indications for their use. However, we still need to continue to monitor the issue of paravalvular leaks and of pacemaker endpoints in our patients, because there does appear to be potentially a higher rate of both compared to stented valves, which we need to look at. But I'm convinced that with proper technique, once we're over the learning curve, and with technique modifications, that these will come down. But large, longer-term randomized studies are underway, and important comparisons with both stented valves and with TAVI, which will better inform us in the use of these devices. So, are we moving from a niche to a new normality? Is this a new spectrum for aortic valve replacement? I think that 2 or 3 years ago, we were in the position where we would be applying these valves in a high-risk population with major comorbidities, and particularly in the frail and the elderly. They would be used occasionally and by small teams, and the outcomes at that stage were uncertain. But now I think we are moving to a situation where these benefits can be potentially widely applicable. We can be reassured over the outcomes at least to 5 years, and so the valves are becoming more accepted and more widespread in their use by surgeons and being used in a variety of clinical situations. There's no doubt that it facilitates wider use of minimally invasive techniques with the advantages that that brings, and it's possible that it may allow us to rival or better TAVI, along with having a financial advantage gained from shorter hospital stays in our patients. Thank you very much.
Stephen,